So a warm welcome to this year's BJS Lecture. In the Swedish Surgical Society, we're very happy to have this cooperation with the British Journal of Surgery Society, and we are very grateful for their support so we can invite people to our national society to enlighten us. And this year, we have the extreme pleasure, I must say, of having Marc Besselink from the Netherlands to give a talk. He's an astonishing person. When I Google him, he has this huge, impressive CV. He will speak for himself, but I can just mention that he's younger than me. That's not something very interesting in itself, but he has, he's full professor. He's an HBB surgeon. He works in Amsterdam, and he has over 750 publications on PubMed, and that I think is really impressive. But the most impressive thing, I think, and which he will talk more about in a minute, is how he unified and got almost all Netherlands to work together to solve research questions and generate new knowledge. So I'm really happy, and I hope you will have a good lecture, and when Marc has finished, there will be time for some questions. His train is leaving just after the session, so we will have time for a few questions. So please, Marc, the floor is yours.
Thanks. Thank you very much for the kind introduction. So clearly it's not me who unified the Netherlands, only our king can do that. But I'm just as a prodigy of the Dutch school, so hopefully I can give you a few tips and tricks of that things that work in the Netherlands and may also work in Sweden. So of course I have disclosures, so for research you need a lot of money, so all the government organizations and all the companies gave us a bit, so it's equally divided. We're all surgeons, so surgical research has been criticized. This is an old publication by Sir Richard Horton. Surgical research or comic opera, questions but few answers. So it doesn't look too good for the surgeons. So we just published a few weeks ago in British Journal of Surgery a systematic review where we put all the surgical randomized trials together. And just put a timer so I don't run over time. And in that, what we did is we looked at the quality and the volume of surgical trials in 3 years in PubMed. So first, I'm going to look at the absolute volume in trials, the absolute volume of trials per country. Everything you see will be per country. And you see in 1999, the USA was #1, and now it is China. And you see in the top 10 ranking, Sweden was here, #6 in 1999, but now is no longer in the top 10. So I need to find a trick that the smaller countries are still higher. So what we then did, we made the relative volume, which is the number of trials per million inhabitants in your country. So then Sweden looks a bit better again here, and the Netherlands is there. So, and actually, if you look at the countries, you see a lot of Northern European countries in there, and Finland is doing especially well. So then you look at methodological quality, so the number of trials with low risk of bias. I don't know where you guys went, but anyway, the Netherlands is here, #2, we're doing pretty good, and China is getting better as well. So China is now the biggest country in the number of trials, and quality is getting better in China. So the Dutch, why in hell the Dutch? What is so special about the Dutch? So I thought about that, and there are some factors. So we have very strong collaboration between centers. We're a very small country between Germany and England, and both have tried to invade us, so we think we need to collaborate. Okay, so that's a little bit of Dutch feeling. And we have the system of PhDs, so we have PhDs who do clinical studies for 3 years. They do not even know where the lab is. So if you do a PhD in the United States, you're typically in some lab doing basic research. Our PhDs, they don't even know where the lab is. They only do clinical work. And then, of course, we like evidence-based medicine and randomized trials. But it's also very helpful, I think, like in Sweden, we do not have a paper procedure. There's a universal healthcare insurance system, and patients are referred to a unit and not to a specific surgeon. So if you want to do MIS or open surgery randomized trial, it is very unfortunate if the patient only comes to you because he knows you do like robot surgery. So that's helpful. And then we have nationwide registries, but I guess in Sweden you even have better nationwide registries. So is there something cultural in the Netherlands? I thought about that. Well, of course, we have the necessity to collaborate. The blue part is where 75% of our population live, and that is below the sea level. So if we do not collaborate, we literally die. So it is in our DNA to collaborate, and that's called polderen. The polder is a piece of land that you bring up. So, for instance, the Amsterdam is here, and you see Amsterdam is 7 meters below sea level. Okay, so we need to collaborate. So we like efficient working. We have a super direct communication style. You may have heard of it, but we also like to build consensus and to be transparent and keep things simple. So all those maybe has some relation. So the next few slides, I'm going to do some boasting to show you how great we are in the Netherlands, and then go back to some tips and tricks. So first, the pancreatitis study group. We got the 40 biggest Dutch hospitals together on pancreatitis. When we started this, there were no studies on pancreatitis. There was just a lot of confusion. And we said, okay, let's work together, surgeons and gastroenterologists, and try to do some reasonable studies. Did we succeed? Well, you may know, yes, we fairly succeeded. This is the first 10 published randomized trials, and as you can see, they're all in a Lancet journal, New England or JAMA. So I'm fair to say that we were fairly successful, but this is the past, this is the future. We got 5 more randomized trials and a lot of prospective studies ongoing in the pancreatitis study group. So we then tried to replicate things for pancreatic cancer. Pancreatic cancer, as you know, is always more difficult because even more specialties involved. But here also already we completed 10 randomized controlled trials. You see them here, not yet in New England, but we got 2 in the Lancet Gastro, and the bottom 4 randomized trials are completed. So again, very happy, and what is important, and that's why I put the flags, and don't worry, there will be Swedish flags in the next slide. We are now collaborating more and more with different countries. So here are the Swedish flags. For instance, a trial ongoing now for neoadjuvant treatment in resectable pancreatic cancer, the PRIOPANC 3, and this trial we hope to start later this year, Panenka, where we will also try to include Swedish and Norwegian centers. And we have 23 prospective studies ongoing. So this is also an efficient group. For instance, the PRIOPANC, just one example, pancreatic cancer, neoadjuvant treatment, yes or no. Of course, it has been shown already for almost all other cancers, but not yet for pancreatic cancer. It was the first completed randomized trial in the world, and survival is still very poor, but at least we improved it from 6.5 to 20.5% because of neoadjuvant treatment. So we are slowly making progress, and we now are repeating this trial with FOLFIRINOX chemotherapy in borderline and resectable. This trial is finished, and at the moment this trial is ongoing for resectable pancreatic cancer, FOLFIRINOX before or everything after surgery. So that's the pancreatic cancer trials. I'll stop with the trials now, and I just want to show you some lessons we learned, and I don't know whether they're applicable to your situation, but I've been doing this for 20 years, and I'm pretty sure they are. So some lessons learned. So start a collaborative group. It seems very logical. Make a website. May seem very logical, but many people forget it. And then a very important thing, make a logo. So I almost never give a PowerPoint presentation with my hospital logo. And you need to think a little bit like soccer. So it's either Gothenburg versus Malmö, or it's the Swedish national female soccer team, which, by the way, were in the plane with me coming over here from Amsterdam. Yes, it was great. But so you need to think like the national team. So we put the logo and we say, if you present any data from the Dutch group, you cannot use your hospital PowerPoint. You are always in the Dutch team in orange. It seems stupid, but these are really, really important things, because you're in a group, and if you see Karolinska present every time with the Karolinska logo the Swedish data, after 3 years, there will be some people will be annoyed, okay? And I know how it works, and it's the same in Sweden and in the Netherlands. So this is very, very important. So it's a democracy, not an autocracy. You need regular meetings, and what's especially important that you discuss the trial designs and talk about it. So what happened in the past, that one professor wrote a protocol behind his desk at a time where we're still allowed to smoke cigars, and then send you the protocol and say, will you join my trial? And you may say yes, but actually in your heart you said no, because it was not really your trial. Okay, so what you need is to spend a lot of time and talk about it and change the protocol, and it takes time, but you will gain back that time in the end because you will include patients faster in your trial, and it will be more fun. And then, of course, point number 4, last one, cherish and build the we feeling, because it should be about the group and not about one girl or one guy. So another thing you can do in the process of doing studies is actually implementing innovation in your practice. And it doesn't matter, I'm going to show a few examples of pancreatic surgery, but this can be done everywhere. So one example is minimally invasive pancreatic surgery, for instance, distal pancreatectomy. So we did a training program. This guy is Moa Bouelao, where I did my fellowship in 2012. He trained us in the Netherlands. We set up a training program, and my PhD drove him to all the different hospitals. And by doing so, we increased the use of, at that time, laparoscopic distal pancreatectomy in the Netherlands by factor 7. The conversion rate in our country decreased from 38 down to 8%. And in the first 130 patients in the implementation study, we had 0 mortality. So we went from the worst country in the world to a top 5 leading country in this way. So this was really useful. So it's both implementation, but of course it's also research. The only thing we told the centers, we'll train you for free. The only thing we want you to do immediately after you've been trained to do a randomized trial with us. And of course they said, yeah, good deal. That was this trial, the LEPARD trial in the Netherlands, where all the Dutch centers participated. The patients were blinded. So for 5 days, they did not know whether the surgery was MIS or open. And that we were very happy with the results. You see minimally invasive, 4 days, functional recovery, 6 days, and all the components were faster. And these results were confirmed by Bergtoft Björnsson from Linköping in also a randomized trial. So then we did exactly the same thing for laparoscopic Whipple, of course, much more difficult operation, but the training went well, 114 laparoscopic Whipples, we trained 4 centers, they did 19 laparoscopic Whipples per year, and the results, conversion, fistula, and mortality rate in the training phase was good. Then we said, maybe a little bit too enthusiastically, we said, immediately again, do the randomized trial, but that did not go so well because there was concern of safety. There were 5 deaths in the laparoscopic group and only 1 in the open group. So we said, okay, and as a country, we stopped completely with laparoscopic Whipple, but fear not, we went immediately to robot Whipple with a 3rd training program. But here what we did is we said we will only train the high volume centers. In the Netherlands, we have too many centers for pancreatic surgery. We have 17 million people, and we have 16 centers for pancreatic surgery. That is now being addressed by the new health minister. But we trained only the centers who do 50, so 50 Whipples per year minimum. So we used the American approach, and Melissa Hawk, Herbert Zay, and Amer Suraikat, they came to the Netherlands for full weeks, and in a week they did 4 or 5 robot Whipples in several Dutch centers. So as of today, more than 1 in 4 of all Whipples in the Netherlands is being done robotically. All of our 8 high-volume centers have been trained. In next month, we will do robot Whipple number 1000 in the Netherlands. And again, this is done with a group. You see Bastard Koekkamp from Rotterdam and Quintus Molenaar from Utrecht. So, but it does all have to be MIS. At the moment, we are doing exactly the same for locally advanced surgery. So, very sorry that these are 4 white males, ladies. It will change in the future. Don't worry about it. But at the moment, these are the experts, and they are helping us, giving webinars, surgical trainings, and we have a nationwide expert panel, like in Sweden, to better and do more advanced pancreatic surgery. In the past, these patients used to go to Heidelberg, but now, fortunately, they can stay in the Netherlands. So again, it looks good, but it doesn't have to be in the Netherlands. We can also do this, of course, in Europe. The diploma trial was published last month in the Lancet. This is a new journal, Regional Health Europe. Has no impact factor, but still, Lancet looks great. So it's a European randomized trial. And I want to show you this because we took a lot of time, because you had surgeons from all across Europe to discuss. So I wanted to show you here that we started in 2015. This was a little bit before Teams and Zoom, several live meetings. And then the first patient was only 3 years later. So it took us 3 years, a lot of meetings with surgeons and pathologists to really talk about the details of surgery. But it really, really paid off. Because this is the inclusion rate, okay? Orange is the planned rate, blue here is COVID-19, but you see in Europe we managed to get it done. So very happy, 35 centers also from Sweden, 12 countries. So this is possible in Europe. Now back to MIS. What we're doing now is we're doing the robot Whipple training program in Europe. So we've sort of exported the training program to Europe. Again, for centers that do at least 50 Whipples, and exactly as I showed you before, we have now trained 18 high-volume centers, including 3 in Sweden. And then every Monday we have groups visiting us as we do a robot Whipple in Amsterdam, which we do every Monday. You see just some of the photos. And we had 3 or 4 teams from Sweden come along. This was the last one. Last Monday, here you see also the team in Lund being trained. So this is now going on in a randomized trial, Diploma 2, exactly same story, patient blinded. All these centers in Europe, including here Linköping in Sweden. And again, this trial even included faster. So this trial, actually, probably next week, the last patient will be operated here in Sweden of the entire trial. And look, we even finished ahead of schedule. So you can do this very well also in Europe. So what are some of the lessons we learned there when we look at Europe specifically? Well, you need to understand local practices. For instance, hospital stay cannot be your endpoint because in Italy, if your patient gets readmitted, they may go to the police. There'll be a formal complaint. So in Italy, patients stay until they're completely recovered. So you cannot look at hospital stay, you need to look at time to recovery, which can be done within this. All these things that we don't know of, they only come up in live meetings or when you drink a beer together, you need to speak a lot to each other to understand. Of course, you need to communicate a lot with people. And what is really helpful at point 4, if you have full-time PhD students who are there, can be called at all time, who take care of the trial all across Europe. And nowadays, I think with Zoom and Teams, it does not really matter anymore if we are working in one country or working in 2 or 10 countries. All the meetings are with Teams or Zoom. And if we travel from Amsterdam to Maastricht or I fly to Stockholm, it is really no difference in travel time also. Okay, so practice variation, and you need to agree, and this is the key point. There needs to be a very detailed paragraph on authorship in the protocol, really super detailed, because the worst thing that happens to you is the day before you submit a paper, someone calls you and say, hey, can you put my 3 friends on the paper? Which is of course not acceptable, but it will cost a lot of trouble. So that needs to be, but you can easily do that. Okay, well, so the final thing, of course you can compare and do studies in your country, but usually within countries, we are so alike that you need results from different countries to actually learn and grow, because everyone is developing new things in new countries. So what we did as my final point in pancreatic surgery, we created something called GAPA Search, where we collaborate with the registries from Sweden, Germany, the United States, or actually North America and the Netherlands, to look at data together. And there are multiple publications. If you're interested, just go to PubMed and look at GAPA Search. But one very simple thing I want to tell you is the ASA score. You know about the ASA score, everyone uses it. We found out that in pancreatic surgery of the Whipples, in Sweden, less than 5% is ASA 3. And in the United States, more than 70% is ASA 3. Okay, we know the Americans are a little bit more obese, but it's not such a big difference, all right? So there's something else going on. So on the basis of that, we started a new study, international survey study with cases, etc. And we're now talking to the ASA Society to try to improve their classification with better examples. So because of the collaboration, you also improve in the way you register and you do research. So my entire presentation can be summarized by this. If you want to go fast, go alone. If you want to go far, go together. And I tried to find out who said this first, but no one knows, so it's just called the African proverb. So then 3 more slides. So pitfalls, very common pitfalls if you want to do collaborative research. Single center trial, it's great, but then you get the not invented here problem. So for instance, there was a trial in pancreatic surgery in Memorial Sloan with a treatment to prevent leaks after surgery, and it was great, but everyone said, yeah, but it's Memorial Sloan, it works only there, my center is different. Whereas you do your trial nationwide, and it's successful, your new treatment is automatically already implemented in your country. So that's why I think multi-center is a second reason to do multi-center. The one-man or the one-woman show, of course, a big problem. Be aware that on stages like this, there are different guys and girls speaking about your group, not every time the same one. Industry taking control. So for the pancreatitis study group, we once had a big company who said, we'll give you 5 million euro to do the trial. We wanted to do something with fish oil. It's fish oil plus something else, and you need to give the control group the something else, which is also a product of our company. And we said, no, we don't care, because the control group needs to be common practice. And then they said, no, then we don't give you the money. And we said, okay, fine, then we don't want the money. But industry will take control, so you need to be very careful. Point 4, don't make the trial too complex. We see sometimes trial case record forms with 60 pages. Everyone hates them. Next time there's a patient, Friday, 4 o'clock, you will really not randomize in such a trial. So keep it simple. The control arm, as I said, not being the common practice, needs to be super simple. The control arm needs to be common practice. Authorship issues, okay, I told them you can tackle that easily in the protocol. And of course, lack of funding, increased costs of the trials and the regulations. In the next slide, I will show a solution to that. So then one slide with some pearls. Okay, by now you get it. Collaborative approach, use the group's brain power. Start with a group of friends, be pragmatic. Give PhD students a leading role because they will by definition have more time than you to do this. And run very pragmatic trials. So that's, I think, an especially important point. You saw our 10 trials from the Dutch pancreatitis study group, all in the New England, JAMA and Lancet. Actually, only 2 of the 10 trials were positive. All the other trials were negative. Something we thought would be great did not work. So why did they get into a top journal? Because we studied something that was being discussed every day, doing handover and doing our rounds with our patients. It was a pragmatic trial. And then, if those are negative, it's also news. So I think that's important. Okay, the next 4 pearls, so be very clear about authorship. And then point 6 is important, and that is something to do with the cost. Use some of the innovative trial designs. I don't have time to explain it completely. You can look at our review in Annals of Surgery. But what you can do, for instance, is the registry-based trial. The first registry-based trial was from Sweden. Is the registry with a name I'm very jealous of. It's called the Sweetheart Registry. I think it's a great name, the Sweetheart Registry. And they did a trial in the New England Journal of Medicine where they randomized some cardiologic treatment with 1,000 patients. They only randomized when the patients came through the door, and they did nothing else. And all the data came from the Sweetheart Registry in Sweden. So that is very important. And then you can do a trial at very low cost. So in a group, but it's the same as in life, try to give a bit more than you take. And what we've done on several occasions, if we have big fights, for instance with our boss of anesthesiology, who's German, we came up with a randomized trial, and then we say the winner takes it all, and then we'll do what comes out of the trial. And so far the score between the Netherlands and Germany is 1-1. So one time he won and one time we won, but at least we got things moving in our hospital, which I think is really great. So conclusion, surgical research is improving. Do pragmatic trials, do nationwide study groups, collaboration, and there are very specific pitfalls and pearls available, and it all starts with friends, and I think that's why the Chirurgveckan is probably a very good place. So greetings from Amsterdam, thank you very much.
Thank you so much, Mark. Brilliant talk. I enjoyed it very much.
Thank you.
It's a bit clearer to me now why the Dutch are so successful. You're squeezed in between in your little country. Yes. But as you said, nothing that you have done is impossible to do here, actually. So I think this was a great inspiration. When is your train again?
My train?
Your train back.
12:38.
12:38. So we have time for questions, and
Yes.
I would encourage every one of you to take the chance now and ask some questions. Yes, please. Is it Malin? Yes. Malin Sund from Helsingfors, Umeå.
Fantastic talk, Mark, very inspirational. So how do you manage to do these randomizations within the heavy clinical burden? Because that's what I feel that people complain. They can't get the trial patients or the time needed within the clinical fast phase.
Sure. Yeah, there's always, I have a trick. There's always a little bit of gray area. So for instance, if you do a new approach, for instance, laparoscopic distal, robot Whipple, leaving no drain, doing a video consultation rather than a live consultation with the patient, all things that the patient wants. Okay? We tell them every time in a randomized trial, this is only available in the trial. Okay, then they sign within 3 minutes. Of course, so what we do in our clinic, for instance, we have centralized the clinic. So on Monday, we have 21 liver clinics, and on Thursday, we have 24 pancreas clinics all day long from all specialties. At the beginning of the hall, there's one student with 3 folders with all the informed consent forms. At the MDT, we address at the end which studies the patient is eligible for, usually about 6. So the doctor, the surgeon in my case, I would explain the patient would go and they would sign with the student. I or the student inform the PhD, and we ask the patient, so what I do is, okay, tomorrow morning, 10 o'clock, can the PhD student call you? And then they have already signed, but you need 24 hours by legal, by the law. Next morning they get called, they can answer a few questions, and then if they say yes, then they are officially randomized. So the answer is, if you do a trial and it's something the patient wants, we have agreed in our groups to only do it in the trial. And you can debate about that, but I actually think if you want to do a trial, you are not sure whether it's better, I think it's ethical to say, well, this is only available in the trial because we don't know whether we should be doing this. And then you keep it pragmatic. And the other thing is in the Dutch Pancreatitis Study Group, we always have a 24/7 on-call pager, so you can call on the mobile phone just a number, and this person takes care of everything. They randomize the patient. But yeah, need to keep it simple.
Can I ask something while
Sure.
we wait for the microphone? I'm really impressed. We've had some Dutch people that I've worked with, and it seems that every Dutch junior surgeon, as you mentioned, they have to start there before even starting residency.
Yes.
They do like 1, 2, 3 years of
3 years.
of writing,
Yeah.
and they're so efficient.
Yeah.
I had a guy, he had 13 papers, and
Yeah.
good papers in his dissertation. I had just 4. How come that Dutch young residents need to or have to do research first? What is the reason?
I don't know who thought of it, but I think it was a great idea. Because they need to do it for 3 years.
Yes,
If they finish, they can get a training position. If not,
they're
I don't know,
out.
they become GP or insurance medicine doctors.
Yeah.
So they work really hard. It's a great job.
Mhm.
They go to Hawaii and Miami, I don't know, congresses, it's a great job. But if they're efficient and they're in a good group with a big database, it is not so difficult to produce a lot of papers. But of course, we are lucky because of this system. About 20 to 30% of the medical specialists did not do a PhD, but the majority did a PhD first to get into training.
Is that regulated by law or by government,
No.
or is just tradition?
I don't know, maybe I need to find out who started with this, but it's
Yeah.
very efficient.
Yeah, thanks.
Thank you for a very nice talk, Johanna from Gothenburg. And I think you answered most of my question by this question.
Okay.
So who's financing the system where they start with a 3-year PhD? Who is taking care of that? Because that's obviously an issue too.
Yeah, it's a big issue. Yeah, it's a big issue, especially now in the Netherlands that all the salaries went up 10%. So for instance, my hospital, we have 19,500 employees. They all got a 10% pay rise, including the PhD students. And the grants did not go up 10%. So every PhD student is 100% externally financed. If there's a PhD, there's 20,000 euro going to the university, or in my case, the boss of my department, but we don't get it back as PIs. So they use it, because we have a huge hallway where there are 90 clinical PhD students at the moment for surgery in my hospital. So you need to get the money through grants, and that is, of course, hugely competitive and difficult. Yeah. That's also why I think collaboration is good in Europe, because I think for us in the surgical field, we need to do more European grants by collaborating. I think I'll get my train in time.
You will, for sure. We do have time for more questions, so just don't be shy. Don't be shy, or everything is just so crystal clear. It was pretty convincing to me. So,
Okay.
we do have some gifts. If there are no more questions, there are a few things to take home
Great.
to the Netherlands. First of all, this great tie.
Nice.
So that's really a beautiful thing. So here's the tie.
Thank you very much.
Here's a little gift.
Okay, thank you.
And here's, let us see if I can,
Beautiful.
a medal.
Thank you
And
very much.
it's a great Olof Akrell, and it's a memory from the Swedish Surgical Society.
Thank you very much. Thank you very much.
Thanks
Pleasure to
so
be here.
much for coming. An honor.